Good morning. It's good to be meeting with you this morning, and I look forward to talking to you some about the state of the art when it comes to CNS tumors. Some of you have visited us in New Jersey. I hope you can come and see us in Morristown and in Summit at Goria Children's Hospital. The problem of central nervous system tumors is an important one in children because it still is considered the leading cause of death from a disease in children, second only to motor vehicle accidents overall. So when it comes to a significant health problem in pediatrics and a significant concern in neurosciences and then child neurology, the state of the art in CNS tumors is a very important topic indeed. So what I hope to do with you today is to just give you a little bit of a sense of what the impact of brain tumors are on life expectancy and quality of life, to give you a sense of some of the molecular advances and the very latest on methionine profiles and what that means in the way of diagnosis, prognosis, and targeted treatment. And then finally, to really understand sort of the evolution of personalized medicine, where groupings of patients with a particular histology no longer fit in terms of traditional clinical trials because it's almost become the case that every child is their very own molecular diagnosis in the way of the CNS tumor. So thankfully, cancer in children is a fairly rare event relative to cancer in the general population, as you can see in this graph here. And we, of course, as child neurologists, are working on this end of the spectrum. And when it comes to central nervous system tumors, brain and spinal cord, the same rule applies. As you can see, the nadir overall for CNS tumors here in the blue, dark blue diamonds is somewhere between 10 and 20 years of age at its lowest. And as you can see, the peak for CNS tumors is really in the 70s. So overall, this kind of pattern of cancer is rare in children, and CNS tumors are also relatively rare in children. So here are some facts. About 20% of all pediatric malignancies, second only to leukemia, pediatric malignancy are sort of common solid tumors. So that's 20 to 50 cases per million children, around 3,100 children per year in the US, and about 100 children a year in New Jersey. As I mentioned, it accounts for the leading cause of death from disease in children, about 2,700 children a year. The lifelong brain tumor incidence is at its lowest between 15 and 29 years of age. And when in stark contrast to pediatric tumors, adult CNS tumors are highly malignant in terms of the frequency. So the most common primary adult brain tumor is a glioblastoma multiforme, which has a median survival of 14, 15, maybe 16 months, whereas the most common brain tumor seen in children is benign, where a gross total resection is usually curative. So that's a stark contrast between adult and pediatric tumors. In infants under a year of age, that accounts for about 10% of CNS tumors. The clinical presentations and pathogenesis are highly variable. One thing to be wary of is back pain, which is very common in the adult population and not so common in children. And children who present with spinal cord tumors often present with back pain and point tenderness. So that should raise a flag anytime you hear a story for back pain in children. There's no question that over the decades, the operating microscope has become by far the most significant surgical advance in being able to tether away a tumor from its margin within the central nervous system. That when it comes to radiation, we're looking at more targeted treatments. We're using proton beams to reduce the spread of radiation. Therefore, at least theoretically, sparing central nervous system development, especially in younger children. And then chemotherapy has certainly found a role in specific tumor types. Immunotherapy is gaining some traction, and very targeted and personalized therapies are becoming the norm. I've always enjoyed this slide, which is a snapshot of the top 5 pediatric brain tumors. And you can see that 1, 2, 3, and 4 are posterior fossa tumors for the most part. Craniopharyngiomas make the list in the top 5 as a supratentorial tumor. When you look at the histologies that are most common in children, you can see that the presentation is really pediatric. And while some adult tumors can be seen, like ependymomas, across the age spectrum, for the most part, there's a sort of dichotomy between histological subtype for pediatric and adult tumors. So presentation is very important because when we're supporting our pediatric colleagues and doing a good job of identifying patients earlier and earlier, we really want to point out this location, the importance of location and examination in terms of figuring out what might be going on. And what do I mean by that? Obviously, a child who's coming in with clumsiness may have a cerebellar lesion. The child with new onset headaches is a very important grouping because headaches are very common as a presenting sign of increased intracranial pressure. And since most tumors are posterior fossa, we're often seeing an obstructive hydrocephalus as a result of the mass within cerebellum and or brainstem. Honig did a very nice study a number of years ago at the Children's Hospital of Philadelphia that showed that children with new onset headaches who within 4 months had not developed papilledema, weakness, or ataxia were very unlikely to have a space-occupying lesion. So what I like to preach, given the sea of children that we see with headaches and migraine, is that a good examination of the fundus and a good follow-up within those first 4 months of onset of headaches usually will tell you which child should have an MRI and which should not. Obviously, any kind of abnormality on exam would lead to an MRI, but if a child has had headaches for 6 months or a year, has a family history of migraine on the maternal side, and has a normal examination, including a good exam of the discs, then the probability of finding a lesion accounting for that you would need to do something about is really very, very low. Then the classic history of early morning headaches or nocturnal headaches, which by the way, we see in migraine as well, but are a little bit more of a flag of there being increased intracranial pressure. Headaches that are changing in quality, obviously with vomiting. If you're unable to see the optic disc, beware of that. You should really be asking an ophthalmologist to help you if you haven't seen the optic disc. Many medical legal cases hinge on the failure to document a good fundoscopic examination in a child with new onset headache. Diplopia can be horizontal or vertical, usually indicates a posterior fossa lesion, though horizontal diplopia can be seen with involvement of supratentorial lesions as well. Normally, if there's facial weakness and combined with esotropia, we're looking at brainstem localization, and so on and so forth. As you can see, the various signs of presentation are very varied, and that they can help determine location and in some cases help determine the urgency with which an MRI of the brain should be obtained. So I've inserted a few board questions. Some are pediatric boards, some are more neurology to kind of help us through this. So we have a 5-year-old who's been having some headaches and vomiting, and yesterday developed some double vision and left-sided weakness. So what will your examination show? Will this patient be alert or sedated? Will this patient have papilledema, a 6th or a 3rd nerve palsy, each of which can contribute to double vision? And will they have weakness on examination? So the most logical combination here is one of a child with a right 3rd nerve palsy and blurred optic disc margins producing left-sided weakness from a right hemisphere tumor, increasing intracranial pressure with some uncal herniation and likely associated sedation. So the logical answer here is C. And this 5-year-old boy has been having headaches and vomiting, and yesterday he developed some double vision and some brisk reflexes in his legs more than his arms. So the emergent CT scan of the brain will probably show. So one of the points I like to underscore on the exam is that we as neurologists are often looking at symmetry, right versus left, in the way of strength and reflexes. But it's important not to omit arms versus legs, because in the early onset of hydrocephalus, those frontal horns are spreading the cortical spinal tracts, which subserve function to the legs principally. And as a result, you can get a picture of paraparesis or diparesis with brisk reflexes in the legs more so than in the arms. So the presence of that is usually an indication of hydrocephalus, and every one of the tumors that is mentioned here can be associated with an obstructive hydrocephalus. And then awaiting consultation by neurosurgery, the last thing to do is, are you going to tell their family their child has a malignant brain tumor? No, that's probably not wise, because though some tumors have all of the configuration of a malignancy with restricted diffusion, high cellularity, the things that are important to do are really elevate the head of the bed, get an MRI, maybe order some Lasix, have ophthalmology consult, perhaps use some Decadron. But the last thing you want to do is to tell the family that the tumor is malignant. That will normally produce a tailspin, which is important not to set off. And a 22-month-old boy is brought into your clinic for persistent vomiting. His mother reports that for the last 2 weeks, he's woken up most mornings, complained of a headache, vomited once or twice. And after that, he's able to drink and eat normally for the rest of the day. He's not had a fever, abdominal pain, diarrhea, constipation, or sick contacts. And on exam, his growth parameters are normal. Heart, pulmonary, abdominal exams are unremarkable. And his neuro exam shows equal use of all of the extremities, normal reflexes, and a stiff-legged, wobbly gait. So of the following, the additional finding most likely to be seen in this child is. So what we see here is head tilt. And head tilt is a product of usually a cerebellar tumor, one that is stretching the trochlear nerve. And as a result, the child is trying to produce a corrective tilt in order to have a perfect horizontal horizon. So let's start with the story of imaging. And there have been some very major developments over the ages. Thomas Edison was actually, believe it or not, the first person to try to image the brain. And publisher Sir Randolph Hearst telegraphed Edison and asking him with his X-ray tube if he could image his own brain. He was unsuccessful and wrote back to the publisher a few days later that he had given it his best try. But through the ages, whether it's the calcified pineal gland seen with X-ray, or whether it's ventriculography through Dandy or Moniz's angiography, there have been really major advances in imaging the brain. And of course, in this day and age, we have exquisite imaging with MRI, not only of structure, of tumor and surrounding edema, as you can see in the upper panel, but also of tracts, and which can guide surgery and can also explain some of the postoperative deficits that come with the business of removing a tumor safely. Toxicity is also being imaged now much more frequently. When we see, for example, with intensive beam radiation, including proton beam, we can see pseudoprogression. So we see a lesion that is enhancing with contrast with a great deal of vasogenic edema, giving the appearance of a recurrent tumor, when in fact it's really a product of the inflammatory cascade set off by radiation and its vascular insult within the tumor. And when thinking about treatment of central nervous system tumors over the last century, there are really three components to think of. There's the operating room and the operating microscope, and here we can see Cushing in the operating room at Johns Hopkins, and every time I see this, for those of you who have seen reruns of Seinfeld, I'm reminded of the episode of where Kramer dropped the junior mint in the operating suite into the womb. But nevertheless, in this span of his career, Cushing accomplished an amazing feat, which is having a very substantial reduction in operative mortality, in part by adopting the aseptic techniques of Lister and the hemostasis, very careful hemostasis, so that these tumors would not bleed out. And then we owe the advances in radiation and rapid use of radium within the hospitals of Paris to Nobel laureates Marie Curie, her husband Pierre, and Marie's mentor, Henri Becquerel, who is to the left of the image. And then Paul Ehrlich, who is really the father of treating syphilis and really father of chemotherapy. I think these three aspects of therapy are still very much mainstay in the way of treating CNS tumors and adult tumors. So for the most part, what we're looking for are great hands, especially in the posterior fossa, where the room for error is very, very small, and tumors can be very large initially, displaying the brainstem. So asking our neurosurgeons to find a normal plane, to do the very best at gross total resection using the microscope, but to not go too far as to produce injury is still very much a cherished set of skills. And then chemotherapy, which, as we say, can be used before, during, or after radiation. Radiation, which has many different dimensions and aspects, with proton beam therapy now being really state of the art. And then in some cases, being able to amplify therapies with the use of stem cell transplant. And very importantly, for some tumors, being patient and observing the biology of these tumors and not acting until it's clear that they're going to be progressive without further therapy. This slide helps highlight what a centimeter can mean in the way of tumor location. I like to use this image to sort of highlight three different histological subtypes that really aren't separated by much if you look. So you have the diffuse pontine glioma, which is still the most aggressive tumor, sitting right smack in the middle of the pons. Fortunately, it only accounts for 10% of tumors. They're usually very high grade, very poor survival. These children are alert and interactive until the very end, which makes them very endearing and difficult to lose. This is still a tumor where the date of expiration can largely be predicted based on the date of diagnosis, which is really a poor statement. There really have not been fundamental advances in its treatment so far that have been significant in a way of reducing mortality, increasing life expectancy, increasing quality of life. On the other hand, the cerebellar astrocytoma is the great story, because once it's resected, and given that it accounts for 50% of brain tumors, it's for the most part is cured. And when we need to do more, I mean, these tumors are for the most part have graft duplications, which are activating the MAP kinase pathway. We have additional therapies that are targeted therapies when needed, but for the most part, when resected, we're done with this tumor. And then medulloblastoma, which is the most common malignant central nervous system tumors, still are a huge challenge, both in terms of survival, but also in the way of quality of life. But when we look at overall, the overall survival in 2020 is about 75% after diagnosis of the pediatric brain tumor. So what we have come to appreciate over many years is that the late effects of therapy really increase with time. And as you look across here in the way of headaches and dizziness and problems with seizures and things that we as neurologists are very much involved in day to day, these have gradually increased in children who have survived their disease and are very deserving of our attention on late effects in the early stages of treatment. So we have really a dual goal. One is cure of the disease, and the other is in preserving nervous system development. So I'll give you Sam as an example. He was a patient of mine who at 9 years of age presented with this posterior fossa tumor, very dense contrast enhancing tumor. And as you can see, it's bowing the brainstem forward, which was a medulloblastoma. And he had a gross total resection. He had some chemotherapy, which he didn't tolerate well, and then had radiation therapy in sort of a standard way, whereas posterior fossa received 54 gray or 5400 rads, and his craniospinal axis received 3600. And one of the unfortunate truths about this therapy at 54 gray, that would include the whole brain and the spinal axis with a boost to the posterior fossa, is that on average it produces about a 3 to 4 point decrease in IQ per year, which is very substantial. So you're starting on average at around 90, and you have, 6 years after craniospinal radiation, very substantial impact on IQ. And here's Sam 10 years later, and these are his complications. So one would ask the question very naturally, is this success? Well, on the one hand, he's survived his disease into adulthood, but on the other hand, he has a lot of morbidity from the therapy that he received. So one of the advances in chemotherapy has really been to enable us to reduce the dose of radiation and spare more of the nervous system. And a number of trials have demonstrated that chemotherapy plus reduced dose radiation is as effective as standard dose radiation. But then if one reduces the radiation alone, then survival is the trade-off. And with radiation, here's one of our patients. The soft mask is put on the face, and then it ultimately hardens to help with positioning. And the fundamentals of intensity modulated radiation proton beam is really to be able to deliver through multiple arcs radiation to the offending tumor while as much as possible sparing the rest of the nervous system. So a 9-year-old boy here is presenting with seizures and an MRI showing a mass in his right parietal lobe, and the tumor was partially resected, radiation is planned. And which of the following tumors is most likely to respond to radiation treatment in the long term? Well, a glioblastoma is certainly not it, and a brainstem glioma, as I've said, is certainly not it. And with medulloblastomas and craniopharyngiomas as options, you can appreciate that a tumor that is a grade 2 astrocytoma stands the best chance of responding to radiation in the long run. A 12-year-old girl has been diagnosed with a malignant brain tumor in which of the following types does not require radiation. Well, here, patients with glioblastoma multiforme will not require craniospinal radiation, though at autopsy, 10 to 20% of patients who've had glioblastomas have seeding up and down the neuraxis. But because the tumor intracranially is so aggressive, that really hasn't been symptomatic in patients, nor has it been a reason for failure of therapy. The primary tumor is what's killing these patients. It's very highly resistant cellularity and molecular mechanisms. So because of these efforts at using chemotherapy to effectively reduce radiation, we've made a good bit of progress. And where the loss of IQ now is about 1.5 points per year as opposed to 3.7. So reducing doses of radiation has been an effective strategy in helping children with long-term survival have fewer late effects. And with germ cell tumors, there have been strategies reducing craniospinal volumes of treatment much the same way to accomplish the same goals. And now I want to sort of point out that while we've had these successes, the revolution in neuro-oncology has been in identifying what the molecular subtypes of tumors are. And I'm showing you here the original tumor classification of Percival Bailey dating back to the 1927, where tumors like oligodendrogliomas and ependymomas and ganglioneuromas and cord plexus papillomas were thought to have a cell of origin. And what's happened with molecular diagnostics and genomics, an explosion in our understanding of molecular machinery driving tumors, is that the tumor classification has evolved very dramatically over the years. So if we look at total tumor types, in the latest iteration of 2016 of the WHO classification, we have roughly 155 tumor entities, whereas back in 1930, that original classification of Bailey had only 13 tumor subtypes. So over the years, we've had this sort of accumulation of cases, increased knowledge about the biology, and advances in technology allowing us to increase the granularity of by diagnosis. This is a snapshot of methionine profiles, methylation profiles. Methylation is a snapshot of where a tumor is in the way of its development. If we think of pediatric CNS tumors along embryological terms, that when the tumor is resected and a methylation profile is done on the tumor, which can now be done in just a few places around the country, it tells us roughly at what time development was problematic and where the tumor had its origin. In fact, this is so powerful that when a tumor is treated and, say, recurs 5 or 6 years later, it has the identical methylation profile. So using this technology, we're beginning to appreciate now that tumors like low-grade gliomas may be molecularly very different tumors in infants or children or adolescents and young adults, and that our treatments need to be tailored to some of these differences, even when the histology under the microscope and the immunohistochemistry look the same. These are molecularly distinct tumors, but are histologically homogeneous, immunohistochemically homogeneous tumors. And expanding this landscape to the most common malignant brain tumor, to medulloblastoma, is giving us groupings of tumors that have provide information on prognosis and allow us in some cases to be talking about intensifying therapy to improve survival, and in children with more favorable molecular signatures and methylation signatures, helping us reduce the intensity of therapy so that their long-term survival is associated with a better quality of life. And this taken to the extreme, if you will, has given us really 13 subtypes of medulloblastoma, 9 molecular subtypes of ependymomas, and has created a new problem for us. So that while a tumor that is Wnt positive medulloblastoma has a fantastic survival and probably shouldn't be treated with very intense radiation chemotherapy, whereas others with unfavorable prognoses should still have more intense therapy. The fact is that conducting clinical trials becomes highly problematic. We're not talking about grouping all medulloblastomas. We really have to target our trials to subgroups, given that the incredibly varied prognoses across the molecular signatures. This, in fact, has enabled us to dismiss a particular tumor type, the supratentorial primitive neuroectodermal tumor. So Lucy Rourke first coined the term PNET when it came to medulloblastoma in the posterior fossa. And small blue cell tumors that are highly dense, that are in the supratentorial compartment, that look like a medulloblastoma histologically and stain with synaptophysin, like a posterior fossa medulloblastoma, are not. And look at the incredible variation on molecular subtypes in these histologically homogeneous tumors. So in fact, the WHO has eliminated supratentorial PNET in its classification for this reason. So all the following statements are correct except one. Please select the incorrect statement. Chemotherapy increases survival and allows to decrease radiation doses. We've shown that. Chemotherapy and radiation are used to treat low-grade gliomas, including patients with neurofibromatosis. Chemotherapy is an alternative to surgery in CNS germinomas, and that's true. Radiation treatment is the mainstay adjuvant therapy after surgery in ependymomas. That's true. And chemotherapy alone can be used in a subset of young children with medullo. That's been true for many years. So the problem here is with B, because radiation is absolutely contraindicated in neurofibromatosis tumors, such as chiasmatic tumors, because of the risk of second malignancy. So the issue is, how do we improve care with all this new molecular data? We have to look at a change in our culture, integrating of information into a molecular diagnosis, not using the wrong drugs at the wrong time, being flexible and adaptable in the way of our clinical trials in light of all this information, and trying to dig more into the biology of these tumors and being careful about limited inclusion of precision medicine in trials. So on long-term survival and on quality of life, the truth is we've had some improvements, but relatively minimal progress. Now we have a lot of molecular information. We're trying to figure out how to incorporate that into decision-making. So in looking at medulloblastoma, for example, in the Wnt subgroup in sonic hedgehog, and then non-Wnt, non-sonic hedgehog group 3s and 4s, there are going to be different strategies, treatment regimens adjusted to these subtypes of tumors. And I think we'll see more and more of that with variations, for example, in doses of radiation to the spinal cord in a Wnt subgroup that has such a favorable prognosis. So with targeted therapies, we're seeing beautiful responses to some specific inhibitors, such as rapamycin or everolimus. So in tuberous sclerosis, we can develop not only tubers within cortex, but also subependymal giant cell astrocytomas, which will respond favorably. And the drug was approved for the SEGAs, or subependymal giant cell astrocytomas. But one of the pleasant surprises is that it also shrinks the tubers in cortex. And we used to think of the tubers as hamartomas, as static lesions that would not grow, would produce epilepsy, and often intractable epilepsy or infantile spasms. But now we can see that they may respond, and has led to the approval of rapamycin for the treatment of intractable epilepsy as well in tuberous sclerosis complex. Interestingly enough, the application of everolimus or rapamycin in lotion form to the adenoma sebaceum will shrink the adenoma sebaceum, because those represent little tubers contained within the skin. And for chiasmatic lesions, targeted therapy can eliminate these lesions and also functionally improve visual field deficits seen with chiasmatic tumors. And then other types of inhibitors, like this MEK inhibitor, can have a very favorable response to tumors involving optic nerve and chiasm. So this is the power of molecular medicine and of developing targeted therapies. And in our patients with neurofibromatosis, who may have tumors that are encasing, for example, the cervical spinal cord and a good bit of the retropharyngeal space, that we have an opportunity to shrink these tumors while maintaining a close eye on stabilization of the spinal column, because some of these have actually very major responses, as you can see here before and after treatment. Here, an inhibitor of a BRAF V600 showing a nice pilocytic astrocytoma and its response to treatment. So currently, the Children's Oncology Group has the pediatric match, which will take a tumor and look at its molecular characteristics and try to match it up with the specific inhibitor. And here's an example of some of the inhibitors. This is provided to me by Roger Packer, showing how various inhibitors and the frequency of their use across a range of tumors. Foundation 1 is another mechanism to molecularly define a particular tumor in an individual child. So let me just sort of summarize and then make myself available to questions or comments from the audience. Over the last 100 years, there have been some remarkable advances in surgery, radiation, and chemotherapy. But we still see a lot of children who are taxed with the disability of survival. So when, as neurologists, we're looking at patients who've had a CNS tumor, we have a role within the early stages and supporting our pediatricians and supporting neurosurgeons and managing patients postoperatively. But we also have an important role in managing late effects and having a voice in managing those late effects early on in the disease process, early on with diagnosis, with cure in mind. Thank you very much for your attention.